Hi, welcome to the Orthobiologics podcast. I'm your host, Dr. Trevor Turner, MD, RMSK, the director of the Center for Orthobiologics at Georgia Bone and Joint. Welcome to our third season, episode 2, Taking It in Stride. Today, we have the privilege to be joined here by Dr. Rowan Paul, who is going to help discuss ACL injuries with us and changing trends in the field of not only how we can manage these injuries using orthobiologics, but maybe some future directions to go in terms of late effects that we see after ACL injury and reconstruction moving forward. Dr. Rowan Paul is a family sports medicine doctor by background. He trained at Stanford, where he was a chief resident, and then did a primary care sports medicine fellowship at the University of Utah, which enhanced some of his interventional training. He then went on to join a large orthopedic group for about 10 years and dabbled in many different side projects, including medical device and robotic exoskeletons, and finally has kind of broke off on his own with a primarily interventional orthobiologics practice with 4 other partners in the San Francisco Bay Area in California. Dr. Paul, thank you so much for joining us today. How are you doing?
I'm doing well. Thank you for having me.
Absolutely. So, Dr. Paul, when you hear the words ACL or when you have a patient come to you with an ACL injury, I think a lot of thoughts come up of this is, athletically can be a devastating injury, can be one that not everybody comes back from in the same condition. Tell me about kind of that conversation that you start to have about, how do you diagnose this and what does it mean for an athlete and maybe even now an aging or an older athlete as well?
Yeah, no, it's definitely one of those big injuries that can be quite catastrophic, as you said. But we have some new treatments and approaches now that can really get athletes back on the field successfully. ACLs are tough injuries because certainly for young people, they tend to be pretty substantially traumatic. Usually the story comes in, it's like, hey doc, I had a sudden cutting event or sudden start-stop event and felt a sudden pop and my knee buckled underneath me and then it blew up like a big balloon and, I had a lot of trouble walking and now it feels unstable and it's buckling on me and I can't do the sports that I want to be doing. And I want to get back. How do I get this fixed?
And just out of curiosity, the majority of patients that you see that come in your office like this, are these people in the kind of high school to early college age, or a lot of them in the sort of late 20s and 30s or 40s age? I mean, tell me about what you see.
Yeah, it's evolving over time. I will say as we are seeing more of a middle-aged to older population staying active or continuing to be active, we're starting to see a different breed of ACL tears that are more of a degenerative type than those acute, massively traumatic types that you see in your like teens and early 20s. So in my practice, I'm seeing kind of the whole gamut of age ranges, but I certainly see a lot of 20, 30, 40-year-olds. I've certainly seen an increase in the older ones. And so it's sort of changed my approach a little bit, for sure.
So, Dr. Paul, you mentioned kind of older aging athletes and degenerative tears versus maybe acute and younger traumatic tears. That kind of leads me to an interesting question. I guess I was talking with a colleague of mine who's been a sports orthopedic surgeon for a long time, and we started having a conversation about, trends and, we've got these new implants coming around, these bare implants and different things. And I said, tell me about how you manage partial ACL tears. And his response was, there are no partial ACL tears. And so I kind of smiled and I said, well, yeah, I mean, we look at different grading systems on MRI and we think about, oftentimes it's more than just one part of the bundle that's torn, but kind of tell me your understanding or tell me how you think through what's the severity of injury and maybe where is there a chance to intervene in a way that is not surgical reconstruction?
Yeah, it's a great, really, really good question. The way I think a lot of us are trained is that it's a binary injury. It's like, you're fine or you have a full ACL tear. And I think the reality is we really have to be thinking in a much more nuanced way as a kind of new treatments start to come out and our understanding of the injury starts to come up. So historically, we've thought about this as like a grade 1, grade 2, grade 3 injury, sort of partial to complete kind of thing. But now we have to realize, hey, the ACL is actually a 2-bundle ligament, and we need to be really thinking about, okay, if someone has one bundle that's intact, one that's torn, or if the intermedial bundle is partially torn and the posterolateral is intact, this may open an opportunity to treat this interventionally and potentially not surgically. But I think these have to be very nuanced discussions, and I spend a lot of time looking at the MRI with patients and doing dynamic ultrasound imaging and looking at laxity, both on ultrasound as well as on my clinical exam. And a lot of it is historical clinical information as well when you talk to patients. As far as like how do I figure out, is someone a candidate for this or not? I think I look at the extremes and say, okay, if you've got a grade 3 complete, tear of, both bundles and your ACL is just in 2 different zip codes, I'm probably not going to be able to get this better, non-surgically. Those are kind of the more obvious cases. But what about the case where the MRI shows signal within, both bundles, but the bundles themselves are quote unquote intact, and the patient is describing symptoms of laxity and,
and what do you, Dr. Paul, when you say symptoms of laxity, what does that mean?
Yeah, like patients will, they'll describe kind of slop in their knees, like excess motions, excess, shifting that they didn't experience before the injury. They have difficulty trusting their knee, whereas before they could. Some of that is a balance thing, awareness thing, a proprioception thing, we call it. And sometimes with these micro or mild partial injuries, they lose that ability. And certainly that puts them at risk for kind of going to a complete catastrophic ACL with other, future exercise and trauma. But that's, I think, when we really have to get in there and intervene before those catastrophic injuries happen.
Yeah, I think that's a really good point. We definitely see, even in somebody who's had an ACL tear that's been fixed and fixed well by an experienced sports surgeon who's done a high volume of cases, we certainly tend to find that there's a higher incidence of re-injury even after that. And depending on what paper you look at, some people even estimate that to be as high as 6 times as the likelihood of an additional injury. So, for that reason, I think people who are motivated to get back to levels of play, there's a lot of consideration about what's the right way to do that. And one of the things that you said that I really appreciated was proprioception, and that may be a term that people are not really familiar with. Can you elaborate on that a little bit?
Yeah, proprioception is kind of the 6th or 7th sense? Basically, it's like your ability to know where you are in 3-dimensional space without the visual cue of looking around. And, some people describe that as balance or stability. Certainly, if you look at, elite athletes or dancers, gymnasts, they have just incredible proprioception, incredible ability to know where they are in 3-dimensional space. And, sometimes as you develop injuries of joints along your kinetic chain, you can lose that proprioception. So, something as simple as an ankle sprain can alter your proprioception and put you at risk for other injuries up or down your chain, So it's something we need to, I pay a lot of attention to the neuromuscular aspect of injury and how do I prevent future injury.
Yeah. And I think, to your point, there's something almost unconscious or subconscious maybe about just an athlete's ability to sort of know, even if they're not thinking about it with their head, sort of know the position of their limb in space and how to move. And I think there is something that is intact there in this kind of, native biologic, this ACL that we're born with that has these two different bundles and they wrap around each other and they attach to different places. And, no doubt that if your knee is mechanically unstable and your ligaments shredded, and especially if you have, injuries to other structures in the knee, just to get stability back in the knee, we have to replace it. But I think sometimes we're looking at what's been considered the gold standard, and you have people argue about whether you should use a patellar tendon or whether you should use a hamstring tendon, or some people even using other things. But we find that, there's something maybe that's native about our ability to assess where we are in space when we have sort of the ACL that we're born with. Maybe that doesn't really exist when we're or doesn't exist in the same way when we're suturing a single tendon back into the space. And maybe that changes a little bit of the way that the torque moves through the knee with rapid acceleration and deceleration. So when you were talking about the two different bundles, I think a lot of times I see patients come in and, they'll say, well, if I had somebody manage this without surgery or try that for a period of time, maybe they've done some rehab or maybe they've taken some medicine and maybe even had a shot. And I've had a lot of people come in and say, well, I had a shot, usually it's a steroid, but they'll say I had a shot in my knee. And then I have to usually then have this conversation about, just because you had a shot in your knee doesn't actually mean you had a shot that was where your ACL injury was or where your ACL is. So talk a little bit about what, why you would say that or what that conversation is about as it relates to maybe treating somebody non-operatively.
Yeah. I think precision is one of the most important things, and guidance, image guidance, I think is the most important thing in terms of treating some of these cases. And if you kind of look around the world, certainly in the US, most shots, quote unquote, are done without image guidance. They're blind injections into the joint, and it may be along the medial or lateral joint line, or it could be kind of in the suprapatellar region. But a lot of times they're anatomic landmarks and not actual direct visualization. And, historically, culturally, the only thing we've been able to inject, for the last 40 years has been cortisone. And we certainly know there's some potential damage that you can get with repetitive corticosteroid use. And, certainly not a great idea after a partial ACL tear. But the reality is, if you're going to be taking on a advanced procedures of injecting an orthobiologic or regenerative substance into an ACL, you really need to be able to see the ACL and guide your needle to it. And really, you can only really do that with ultrasound or fluoroscopy, moving X-ray guidance. And so, when I talk to students and fellows and other doctors, and I try and impress on them that, it's not that the, platelet-rich plasma or bone marrow or stem cell type procedure, it's not so much the substance, it's as much the direction, like where you put the needle, and being able to have confidence in where you put the substance that can make or break the outcome. And so I'm very meticulous, almost OCD with kind of putting the needle in the right places and being sure that I'm in the right place before injecting.
Yeah. And so you've been doing this since 2008. And I think a lot of people who practice in orthobiologics probably recognize that trying to do an ACL sheath, injection is kind of one of the more advanced techniques maybe in our arsenal and can have a steep learning curve in the beginning. And so, I heard you mention ultrasound earlier, and, I'm a huge fan of it. Definitely a big ultrasound guy. I think if we can minimize radiation to patients, we should always try and do that. Can you talk about, maybe like, how do you make that decision? Are you using ultrasound mostly if you're trying to inject the ACL? Are you using fluoro? Do you use a combination? I mean, talk about that.
Yeah, I think it really depends on the patient and which bundles are injured or torn. I think it's pretty straightforward to see the intermedial bundle, and in some cases, I spend a lot of time looking and hyperflexing patients' knees and trying to really see if I can see kind of origin insertions. And certainly we can see it on the tibial side. It's the kind of femoral side that can be tricky sometimes. So, but if you have an answer,
you mean it's hard to see it, whether it's kind of coming from the bottom bone of the shin or the top bone of the leg? That's what you mean?
Correct. Yeah. And it depends. Some people you can see it pretty easily. Some people you can't. And so if I can see it, I can inject it. And if I can't, then I'm not. And so I spend a lot of time kind of mapping it out before I do anything. And so I think, sort of the posterior lateral can be a little tricky under ultrasound. I think, the gold standard would probably be doing it under both ultrasound and fluoroscopy. But I think in some cases, if you can see it well and you spend a lot of time and you're really confident with ultrasound, it is technically possible to do both.
Okay, interesting. Yeah. And so I think, anytime patients are looking for information, we kind of have this discussion about this is what's in the evidence. And then let me tell you about my experience. And then you need to know that this is me telling you a story based on patients that I've seen. And we do collect outcomes data. So I think we can reference that. But pretty much the two, maybe biggest studies that I've seen regarding the use of whether it's, PRP or platelet lysate or bone marrow concentrate to treat these partial ACL tears came from a group in Colorado, Dr. Centeno's group. And, the first group of patients, there were 10 patients in it. And the second one had 23. So, and they were good. I mean, the outcomes were good. The people seemed to have, decrease in their pain. They seemed to have improvement in their function. Right. Obviously with a clear advantage of not having to do a major surgical rehab when possible, because it is a long rehab and it's a tough rehab, but,
sure.
But we don't seem to have an abundance of evidence regarding techniques for injection of the ACL. How do you have that conversation when somebody comes in your office?
Yeah, I think you have to be pretty honest with patients and be like, look, this is kind of the tip of the regenerative spear, and it's kind of one of the trickier procedures we do in this field of interventional orthopedics or orthobiologics and sports medicine. I really try and impress upon them that, look, this is not a procedure that you can, go down the street and find someone to do this randomly. There's really only a very select few in the whole country that can really take this type of procedure on. And that's number one. And number two, when you look at, Chris Centeno's study, these are some very well-trained doctors who kind of, as a rule, are being very meticulous and doing it for research purposes. So this is kind of like a best outcome sort of scenario. And, patients are selected very carefully. And so usually what I say is, all right, you need to be a great candidate for me to take this on. Certainly if you have a desire to get back to your sport, if you're a professional athlete, which I've treated several. If you are an amateur athlete, weekend warrior, you still, I'm very careful with my patient selection. And, if there's any doubt and there's, major laxity or major instability, I really kind of say, look, man, like you really ought to get a couple opinions from a couple surgeons and see if reconstruction would be better for you. But if it's a kind of a milder case or, a patient with lower demands or medium demands on their knees and ACLs, if they're just, for whatever reason, they're not great surgical candidates. And certainly, as we talked about earlier, there's an older patient population who are getting these degenerative ACL tears that, may not want to go and get their ACL reconstructed at age 52, and yet they still want to be super active and play basketball and whatnot. So I'm pretty honest with patients that, look, the data is scarce, but certainly it's an area of intense study. And I think in the next 2 to 3 years, we're going to see a lot more published studies on ACL repairs and augmentation of surgery with biologics, of which there's certainly some evidence now, and as well as kind of percutaneous ACL biologics injections. But right now we're still in the early stages.
Yes, I appreciate you bringing up that patient selection in particular. And we, as an orthopedic group, we probably do a lot more ACL repair here and revisions when we got to do them as well. And do you find that patients are starting to ask, or surgeon preference is starting to change in maybe your region or your area in terms of whether somebody's getting their ACL repaired surgically and also saying, can I get PRP? Can I get bone marrow concentrate? Do I get some type of, cellular substance to augment or basically improve, my graft? And is it worth it? Is it not worth it? I mean, what do you find in that regard?
Yeah, I mean, I think, I did a sort of an informal poll of some of my orthopedic surgical colleagues before this, and like, hey, are you guys using this or not? And in the OR, and what has your adoption rate been this year versus last year, and last year versus the year before? And certainly there's now a trend in my region towards doing it intraoperatively for ACL, after ACL reconstructions. There's a couple kind of more nuanced surgeons in our area who I appreciate that are doing some pretty cool stuff where they'll do a reconstruction with whatever they're going to reconstruct with, patellar tendon, hamstring, or allograft, and then they'll actually sew in the stump, the ACL stump, into the graft, and then we'll inject the stump as well as like the ACL graft with PRP or less likely bone marrow. And I think, my patient population tends to be a fairly educated one. They certainly are. I'm in the Bay Area, and there's some, it's just kind of a smart engineering type of group. And so they'll come in with papers and be like, hey, I read this thing, what do you think about this? And so I find myself having some pretty cool conversations with them about that. But, I think, on balance, I certainly think it's not going to hurt to get it done intraoperatively to augment your ACL reconstruction. I think it has a chance of helping with kind of vascular ingrowth and improving proprioception and improving kind of neurologic ingrowth as well. So I think it makes sense to me to use it if you have that option intraoperatively.
Yeah. So it sounds like what you're trying to say is that we don't have a ton of evidence, but maybe more people are starting to use it when they do their surgery. And the reason for using it may be that it can promote kind of new blood vessel formation to get healing there, and maybe promote, the way that the nerves otherwise heal after that procedure. And I think, we have patients asking that. I think maybe sometimes we make decisions about, we find a lot of ACL injuries where we get injuries of other structures. And so if we have a cartilage lesion, maybe that's a good reason to consider bone marrow concentrate. If we have a meniscus lesion, right, do we talk about PRP or not? And so sometimes it's not even just the ACL itself, but treatment of some of the other things. And, one of the things that we really haven't seemed to come to a consensus on is, if you make the decision that you're going to get your ACL repaired, is it actually better to go ahead and put it in at the time of surgery? Or maybe is it better even to do afterwards, whether that's a few weeks afterwards or a month afterwards or beyond that? And I think there's some people out there who feel, okay, well, now we have a mechanically, more stable joint. We've got a fresh, wound, for lack of a better expression or way to say it, that would otherwise be kind of ripe or opportune for receiving a dose of growth factors or messengers or cytokines or chemical cells that otherwise would help somebody have improved function with less pain a little bit faster. So do you have a opinion on that?
Yeah, that's a really hot topic, I would say. So I will say my personal belief, having, I guess, sort of, I would call this anecdotal evidence, but yeah, again, like you, I'm tracking outcomes and stuff, and I actually find that I think patients kind of go through an apoptotic stage and kind of an inflammatory stage that's probably a little toxic for biologics right at the time of surgery. Plus, there's a question of dilution with arthroscopic fluid and stuff like that, and they're immobilized or non-weight bearing, and we know that there's some biomechanical stimulus that can kind of trigger or help teach these cells what to do and stuff like that. So I'm actually moving to more of a, hey, let's get you out of that acute surgical window and then kind of work the biology side of things. And so I'm doing a lot of post-surgical augmentation with orthobiologics as early as 2 weeks, but certainly out to like 6 weeks, depending on what we're treating and whatnot. And so far it's been certainly beneficial. I think we have to learn more but I think, again, hundreds to thousands of procedures later, that's kind of where I'm leaning. But I still think, and it may not be an either or, you might consider doing both. I think we're learning, certainly with regard to kind of bone marrow derived cells, and is that environment plays a big role. And if you're injecting these cells into a toxic environment, their viability is not going to be as good, and you might get more cell death, or they might act in a more purely anti-inflammatory way instead of a true regenerative way. And so I spend a lot of time trying to get my patients' joints in a quiet place before I inject an orthobiologic like bone marrow derived graft or even PRP for that matter.
Yeah. And so I really, I guess I appreciate the way you describe an environment. You said toxic environment was one of the words that you used. And I think, we've kind of known probably for a long time in sports and orthopedics that if you tear your ACL when you're young and you're in your teens or maybe your early 20s, that, you got an unstable knee, you probably are going to get that knee fixed because you have a long, period of sports or active life or whatever it is that's in front of you. With the downside being that we know in 15 or 20 years that your joint is going to degenerate more quickly. And, we start seeing people who are in their 30s and 40s having a lot of features of osteoarthritis, which is something else we've talked about on the podcast before, that now maybe are at risk for earlier joint replacement and are getting joint replacements in their 50s as opposed to, 60s or maybe later. And what implications does that have on a patient? But I think, for biologics in particular, I think the really maybe relevant or interesting question is, well, how early does this process really begin? And I think it wasn't until about 2018, we had a great paper that came out in the American Journal of Sports Medicine, and they took 78 patients who had ACL injuries, and some of them were combined, some of them were not, which is, representative of the population we often see. And they followed them out from 1 year and 5 years, and they used a grading system with MRI, and they had a very experienced radiologist who was looking at these and grading these cartilage lesions. And what they found at the end of the study was that there were worsening features of osteoarthritis in more than 2/3 of these young patients, even within kind of that 4-year period, that first, year to 5 years after getting a great ACL repair. And so, I don't think there was ever a question that we were restoring stability to the joint, but the question is what is happening biochemically inside of there, after that. And now, do we really have a chance to modify that disease progression going forward? So, do you find that you have a lot of people talking to you about that? I mean, are people saying, how can I prevent osteoarthritis later in life? And that be a purpose of getting a biologic as opposed to just for repairing the ACL itself?
Absolutely. This is again a hot topic. I think orthopedics and sports medicine historically has been a bit of a damage control field. You injure something, you fix something, but I think we need to really shift the culture a little bit to more of a preventative one, and maybe that starts with early screening in high school, or in your 20s, or take a detailed family history, just as you would if someone comes in with hypertension, or pre-diabetes or hypertension, or their parents all had cardiovascular disease, and that would change your risk profile for your patient. We probably should be asking about family history and say, okay, did your dad tear his ACL? Did your dad need a knee replacement at a younger age? That kind of thing, and I think should influence how we treat our patients. But yeah, I think there's two questions. There's primary prevention and there's secondary prevention, and I think that after an ACL reconstruction, certainly, as you said, the risks are about the same whether you reconstruct or not. But it is definitely an increased risk that you're going to develop post-traumatic arthritis, and so if it's almost a foregone conclusion, I really think we should be working hard to prevent that. We know that if you sample a knee after an ACL reconstruction, that what you get in terms of on a chemical level, you have erosive chemicals that are actively degrading your joint, and even if you have beautiful stability from that ACL graft, like you said, your cartilage is being eroded, not just mechanically, but chemically. We know that ACL grafts they tend to be a little bit steeper, a little bit more vertical. They're not a direct replacement for your native graft. And so your kinematics are changed, and in that you get different translational loads and rotational loads, and that may increase your risk for cartilage wear, but also your biochemical milieu or biochemical mix of stuff floating around. Your synovial fluid changes as well, and so I think it's on us as physicians to talk with patients about that concept. You're not out of the woods after you get your ACL. You should be on like this more aggressive screening program to see, are you rapidly or degenerating your joint faster than expected. And if you are on some downhill trajectory, we should get ahead of that. And that would be kind of a really good candidate for orthobiologics like platelet-rich plasma, or bone marrow concentrates and adipose type stuff, growth factors and whatnot.
Yeah, and I appreciate too that you mentioned kind of diabetes and hypertension. I think in that that paper I was referencing, one of the things they clearly spelled out, or that they found on MRI follow-up, is that people who had a baseline BMI or body mass index that was greater than 25 consistently developed greater odds of worsening cartilage lesions or worsening cartilage problems, basically in the ACL repaired knee, and sometimes up to 5 times the native risk, as well as kind of older age being defined as greater than 26, which
right.
that sounds young to me, but as showing that they were going to have greater odds of worsening disease, especially kind of in that compartment behind the kneecap in particular. So,
Right.
So I think maybe even when it comes to risk stratification, we should be thinking, okay, well, if you're a little older, higher BMI, do we need to be more aggressive in how we manage maybe your post-reconstruction process, whether that's with a biologic or even with, some other types of means to reduce risk, I think. But so
I agree.
That was really insightful. I appreciate it, Dr. Paul, because we, of all the things probably we talk about on the show, I think ACL is kind of a really exciting part of the field, but it's also one that doesn't have just a huge abundance of data behind it when it comes to the use of biologics to manage these injuries. So I appreciate your experience and your insight in that regard. So Dr. Paul, you are located in the San Francisco Bay Area, and then I think Region Core is the name of your group. And tell us what your website and social media handles are in case patients are trying to find you.
Yeah, sure. I'm certainly very active on LinkedIn, Rowan Paul, MD. Our website is www.regencoremethod.com. You can certainly find me on Instagram. I think it's SF Bay Area Sports MD, and on Twitter as well. And then, yeah, if you really kind of want to get deeper into kind of the nuances, I think LinkedIn is a good place to start. The Biologic Orthopedic Society is a wonderful kind of resource for seeing the discussion, and it's we certainly have healthy academic arguments, and it's a good place to kind of see who the most interested players in the field are, honestly. And but yeah, it's we're lucky to be where we are at this specific time, because we're really seeing a paradigm shift in how we treat these types of injuries. And I think we're all going to look back at kind of these last 10, 15 years and be like, wow, that was when orthopedics became, less of a surgical field and more of a kind of a minimally invasive field. Just as cardiothoracic surgery everything used to be open, and then everything became, like angioplasty and, like all these, percutaneous like valve replacements and cool stuff like that. So I think it's really exciting to be in this field at this specific time. So
thank you so much. We appreciate all your time, Dr. Paul, and thank you for joining us on our second episode of season 3, Taking It in Stride. Again, I'm your host, Dr. Trevor Turner, MD, RMSK, as the director of Center for Orthobiologics at Georgia Bone and Joint. You can check us out online at georgiaboneandjoint.org or check us out on Facebook. Thanks for your time.